Hi, I'm Dr. Marley Madora. I'm a women's mental health fellow at Brigham and Women's Hospital, affiliated with Harvard Medical School.
Hello, I'm Dr. Ruby Vaughn. I'm a consultation liaison psychiatrist and reproductive psychiatrist at the Montefiore Medical Center in New York City, where I'm also an assistant professor of psychiatry and obstetrics and gynecology. This was a case that we saw here at Montefiore Medical Center a year or two ago of a young woman who came in labor delivering her first child with no major psychiatric history, but she did have some anxiety symptoms, and as we learned later, some depressive symptoms during the pregnancy. But about 1 day postpartum, the patient experienced generalized convulsions that were witnessed by her partner in the bathroom, and there was some concern. Was she seizing? Neurology saw her, was not particularly impressed with potential for seizure. And so we were consulted to figure out what was going on, why was she having this mental status change. And what we found upon talking to the patient, her partner, her family, was that she was experiencing psychotic symptoms. She was having prominent visual and auditory hallucinations of her baby being on the floor. She, even though her baby was not on the floor, her baby was safe in the nursery. Um, she believed that her baby didn't belong to her, that her baby didn't love her, and her partner was also very concerned because she really hadn't slept in several days and just seemed very confused and not at her baseline. Her symptoms progressed to the point where I think we saw her 2 or 3 days postpartum, and she actually displayed signs of catatonia with mutism, upper extremity rigidity, significant cognitive changes, not feeding herself, not engaging, completely withdrawn.
When we were working together on this case, as her vital signs were becoming very unstable with this dysautonomia, it wasn't just catatonia, it was something more scary than that, or something called malignant catatonia. So that is what made us very concerned, and we were able to communicate with neurology, obstetrics, the ICU intensivists, and we were able to get her that higher level of care in the ICU. And it was really this team approach that was able to get her the best treatment. When we were thinking about malignant catatonia in this young woman, she was 18, who was 3 days postpartum, our differential diagnosis was really broad. So we were thinking about anything from regular infection to autoimmune disorders, thyroid disorders, protein such as urea-cycle disorders, which can happen postpartum, and also psychiatric conditions that can lead to catatonia as well, such as postpartum psychosis was kind of top of mind for a psychiatric condition that could do something like this. And she really received two types of treatment. So we were very concerned for autoimmune encephalitis. We were waiting on labs to confirm this diagnosis, but because we had a high index of suspicion, the neurology team wanted to treat her as such with immunomodulators such as steroids, which she received. We were also concerned for postpartum psychosis. And the reason we were concerned for postpartum psychosis is that she had psychotic symptoms, but she also had delirium. And with postpartum psychosis, about one-fourth of people with this condition will have waxing and waning mental status consistent with delirium, and even 5% of people with postpartum psychosis will get catatonia even. And that led us to want to treat her for postpartum psychosis with mood stabilizers as well as benzodiazepines to kind of quiet down the nervous system and also treat some of the catatonia involved.
I think just to drill down on another component of the case is she did have multiple readmissions even after we saw her for that index presentation. So she was discharged stable after having had high dose steroids for 5 days and some Abilify. Then she came back to the hospital 3 more times. Although Dr. Madora and I were not involved in her care during those 3 readmissions, what this case sort of highlights is that whatever we did that worked didn't last. And so the question remains for both Dr. Madora and myself is it that the psychotropics that were used to continue to manage her were not enough? And so that was a question about, why wasn't she getting better? We weren't rushing her out of the hospital by any means. And so the question remained, did we have the diagnosis correct?
Another component of why her treatment was difficult was that, she was younger, she had good family support, but this was all new to her. She didn't really understand what was going on. It wasn't like somebody who's had lupus for a while and they understand their lupus flares. This is somebody who had never experienced being in the hospital before. There weren't many clues in her pregnancy that she would develop this kind of malignant catatonia, potential autoimmune disorder, or postpartum psychosis postpartum. However, there were some nuanced symptoms that the psychiatric team was able to hear later in the course. She did have some depression and some anxiety during the pregnancy, which does put women at risk for postpartum psychiatric symptoms. And also, I do want to mention her age. So she was 18 years old, pretty young, and often with postpartum psychosis, the underlying disorder, more times than not, is a bipolar disorder. And with bipolar disorder, usually in late adolescence is when people will have kind of their first episode. And it's very possible that kind of during the pregnancy, that's when some of these very mild symptoms of depression, hypomania, mania were happening, but it wasn't until the postpartum period that they were really able to emerge.
Primiparity, so this being your first pregnancy, is one of the known risk factors for postpartum psychosis. This was her very first pregnancy. And so, what is unusual and also pretty, frightening about postpartum psychosis is that many girls and women go through their whole adolescence and young womanhood having no idea that they have an underlying bipolar disorder or bipolar diathesis. Then they get pregnant for the first time and they deliver their first baby. Boom, they have postpartum psychosis. And for a lot of women, this is the index case for them having bipolar disorder.
People with bipolar disorder are often more sensitive to the hormonal fluctuations that happen during pregnancy and postpartum. So often somebody will have very mild symptoms of bipolar disorder, never get diagnosed, never need to receive treatment. And it's not until they become pregnant or postpartum that these symptoms will come out and need to receive treatment.
In a case like this, where we're considering postpartum psychosis versus autoimmune encephalitis, what do we expect for women who experience this? It depends. So if we think that this is postpartum psychosis, there are a few possible outcomes. There are a subset of women who experience postpartum psychosis, and as long as they're not pregnant or postpartum again ever in life, they won't have psychiatric symptoms. But if they become pregnant and postpartum, the likelihood of recurrence is about 31% in women who've had postpartum psychosis, that they will have it again in subsequent pregnancies. So it's possible she could do great, and if she doesn't get pregnant again, she doesn't have symptoms again. There are, like Dr. Madora was mentioning, women for whom postpartum psychosis is the first sign of true bipolar disorder. And so their course may look very similar to other people who have bipolar disorder. So, they'll sort of cycle between depression and mania, very likely get very sick with postpartum psychosis should they decide to have another baby. So those are the most common outcomes from postpartum psychosis. If we believe that this is autoimmune encephalitis, as I mentioned before, a patient like this may need multiple different rounds of, IVIG, high dose steroids, sometimes other biologic agents to sort of calm down the central nervous system and hopefully have a full recovery.
The large take home points of a case like this, um, for me, I really like to zoom out and think about how neuropsychiatric symptoms are very common in the postpartum period. And it's really important for all providers, whether they're psychiatrists, OB-GYNs, intensivists even, to take a really broad lens and think about the differential diagnosis. And while many people with medical conditions such as autoimmune encephalitis will have psychiatric symptoms such as psychosis, delusions, hallucinations, it also goes the other way around too, how people with postpartum psychosis can have delirium, can have other kind of neuropsychiatric symptoms that we must be aware of. And also that there is an overlap of these symptoms and the etiology. So in this paper, we think about the hormonal changes of pregnancy and postpartum, and also the immunologic changes of pregnancy and postpartum. And they all work together. So during pregnancy, Dr. Vaughn had mentioned that there's these intense hormonal shifts, the estrogen and progesterone climbs and then plummets postpartum. And there are similar changes in the immunologic system during pregnancy and postpartum. In order for the immune system to not attack the baby, the immune system needs to tone down a little during pregnancy, and often it really ramps up postpartum. So we talked about the psychiatric risk increasing during pregnancy and postpartum, but this also happens with immunologic conditions really increasing in the postpartum period. It's more likely to have lupus flares postpartum. It's more likely to have things like autoimmune encephalitis postpartum, where the body creates antibodies that don't attack something else, they actually attack your own brain. And that is what gives you those neuropsychiatric symptoms of potential seizures, weakness, psychosis even, and how there's all these overlapping features of psychosis and autoimmune changes that we all need to think about. And it's important to not pigeonhole patients because the treatments are so different, and each treatment has a very long list of side effects. It's important that we don't accidentally give our patients the wrong treatments, because then we're exposing them to these side effects. It's often harder for them to get back on track to receive the right treatment, and then we're not going to get our patients well. And we know that in the postpartum period, it's a mother, but you're really thinking about the whole family unit. And we really need to think about how do we get this mom as well as possible, as quickly as possible, so that she's able to function for herself and also for her family.